Thank you, Dami Lola, and the
Yes.
Institute of Nursing Research for having us here today. It's a teamwork, as well. So thank you for introducing myself and Suzanne. On the call, we also have Rachel Howard. Rachel, do you want to quickly introduce yourself, please?
Hi, I'm Rachel Howard. I'm one of the senior lecturers at John Moores University, along with Oladeo and Sue. My background is critical care nursing, but then my master's degree was in public health, focusing on social inequalities. Nice to meet
Thank
you
you,
all.
Rachel. Thank you, Rachel. I think that will just take us straight away to the next slide. And we have the CEO of Mary Care Foundation to sort of talk to these slides as well. Over to you, Mary. I'm not sure if we can come back. We can come back to this slide. Sue, do you want to sort of make a start with our presentation, please? Thank you.
Hi everyone, thanks for coming along today. So the aim of the session today is to introduce ACEs and what they are and what they mean. So ACEs is adverse childhood experiences. So we're going to look at them and gain an understanding how they impact on lives long term. So it's not just around childhood, it's around us moving into adulthood as well. We're going to look at the benefits of good attachment between children and caregivers and how this can impact on the resilience of children and potentially counteract some exposure to ACEs. We're going to look at what toxic stress means and consider how that impacts on development. And then we're going to quickly explore what we can do as professionals and within our local communities to address the issues. Okay. Can you see that QR code, Oladeo, that I've just put on? Yeah.
Yes.
Okay.
Come through.
So just in case you've missed the link in the chat, that's the QR code for the pre-training assessment. So if you wouldn't mind scanning that and start to fill in that questionnaire for us, that would be brilliant. Thank you. Okay. Why is this not changing? Well, there we go. So what are adverse childhood experiences?
Sorry, so sorry to interrupt. The whole slide is not coming through.
Is it not?
I don't know if that's just for me.
Right, okay. Let me turn that off. Stop sharing. Right, let's try again. Okay, can you see that now?
Partially, but let's move on. Let's see if you need just, yeah, okay. It's coming through now.
Is that changing? Yeah.
Yes.
Okay.
Thank you.
Brilliant. Okay. So what are adverse childhood experiences? Okay. So they're potentially traumatic events that occur within childhood. They're events that greatly impact on children and young people throughout their lives. So as I said, it's something that will happen within childhood, but it will impact through the whole of their lives. And the World Health Organization have suggested that basically ACEs are some of the most intensive and frequently occurring sources of stress that children may suffer early in life. Okay, but what actually is ACEs? What do we consider to be an ACE? These are our 10 different types of ACEs that are currently considered and have been identified. Generally, these are all within the home environment. Okay, so we're looking at different types of abuse, so physical abuse, emotional abuse, and sexual abuse, neglect, physical and emotional neglect, and household dysfunction. So any mental illness within the household the child's living in, relatives from the household that have been placed into jail, so they've been incarcerated. We've got domestic abuse. It says here that the mother treated violently, but actually it could be the father's treated violently by the mother or via another partner. Substance abuse and divorce. So these are the 10 ACEs that are identified in all of the research. However, there are now more ACEs being identified, so we're starting to consider things from outside of the home environment, such as bullying, discrimination, and things like that. So it's not, presently we are talking about things that happen with parents and carers in the home environment, but we are starting to consider what happens outside of the house is actually really important and can have an impact as well. And so what does all of this mean? Basically, it has a massive impact from birth to death. So children at the bottom here, they are exposed to adverse childhood experiences, which can then disrupt the nervous systems, the hormone development, their immunity development. It can impact on the social, emotional, and learning as they get a little bit older. Because they've not got the ability to thrive in a social environment or a learning environment, they then start to look at adopting health harming activities. So they'll start taking drugs, drinking alcohol, they'll turn to crime to fund those habits as well. They could have underage sex, they become pregnant under the age of 16. So we're looking at all those really health harming activities that can be detrimental to their physical and emotional health. Again, because of potential lack of education and lack of social skills, we then look at social problems later in life. We're looking at people that can't potentially get a job, therefore they've got really kind of low economic resources. There's potential that people will suffer disability because of this, and then they start to suffer non-communicable diseases because of the life that they're living, which potentially then results in an early death. So if we look at some of the data, so this is data that has come from England because this is where most of the research has been done so far. So what we're looking at is almost half of the population have reported that they've been exposed to at least one adverse childhood experience. And around 9%, so almost 10%, have reported that they've been exposed to 4 or more ACEs. And what the research is telling us is that people that are exposed to 6 or more ACEs in that early childhood, it reduces their life expectancy by around 20 years. So if we go back to our triangle, that kind of makes sense. We've got, children down here, they're exposed to 6 or more ACEs. It impacts all of these things, and then we get an early death of around 20 years because of their exposure in the early childhood. So thinking about long-term impact, if we break it down a little bit, so think about our health outcomes. We've got increased risk of chronic diseases, so heart disease, cancer, diabetes. And again, this is not just a standalone. So I'm not kind of sitting here saying if you're exposed to ACEs, you're gonna have heart disease. There's everything stacks up. So if you're exposed to ACEs, you've got a potential to have a lower income, so therefore you've got a poorer diet, therefore you've got a greater risk of heart disease or diabetes or cancer. So it's all of those things stacked up against each other. We've also got higher rates of mental health issues. So think about depression, anxiety, post-traumatic stress is a massive one. So these children that are exposed to these really toxic environments eventually will potentially suffer some post-traumatic stress later on in life, especially as they start to see how other people live and how other families work, that can really trigger them. So our behaviours, as we've said before, we've got an increased likelihood of risky behaviours, and then our lower educational achievement impacts on our life outcomes. We've got higher unemployment rates of people that have been exposed to ACEs, and then we've got increased likelihood of poverty, which then impacts on all of these things as well. Okay, so they're all kind of interlinked, these outcomes, and it is quite a complex issue. So just again, a little bit more about impacts. Some people like diagrams. So there you go, lovely diagram. And what this is talking about here is people that have been exposed to 4 or more ACEs. So what we've kind of found so far from research, if you're exposed to 1 to 3, you kind of generally do okay, although maybe not. But actually it's those that are exposed to 4 or more is where we're seeing the real impact. Okay. So thinking about those that have been exposed to 4 or more ACEs, they're 2 times more likely to binge drink and have a poor diet. So that then in turn impacts on their physical health. Same as smoking. We've got them 4 times more likely to have low levels of mental well-being and satisfaction with life. We've got those risky behaviours here, so 6 times more likely to have an unplanned teenage pregnancy. Then we've got 7 times more likely to have been involved in violence and 11 times more likely to have used illicit drugs, and therefore 11 times more likely to have been incarcerated. So this kind of illustrates the cycle. So if we've got a child down here that's exposed to 4 or more ACEs, they then start to adopt these behaviours, become pregnant as a teenager, take drugs, become involved in an abusive relationship, end up in prison, and then this child that was born here is then being exposed to the same ACEs as the parent. Okay. So this picture here, a lot of you may have seen this. It's used widely to demonstrate the impact of neglect on our brains. Okay, so we've got a normal 3-year-old child's brain here, and we've got a child here who's suffered extreme neglect at the hands of their parents or carers. So basically what this is illustrating is a lot of what happens during the development of our brains in the first 2 years is impacted by the attachment and by the relationships that we have with our parents or caregivers. So our brain doesn't actually fully develop until we're around 25 years old, but the majority of the growth of the brain happens in the first 2 years of life. Okay, so that brain will grow. When we're born, it's around 25% of its actual size. By the end of 2, by the age of 2, that brain will have grown to 80% of the actual size. So it does a lot of growing in those first 2 years. And what they found is that brain connections, that's what makes the brain matter grow, is by creating and forming connections with the neurons in the brain. And what they found is that these neurons grow and connect basically by the experience that the brain has and the child has. And a lot of that is to do with the attachment and the care provided by parents or caregivers. So it's all around our daily experiences, building those connections. If we don't use connections that grow, the brain actually physically prunes them away. So if you think of a rose bush in the winter, you prune it off so that it grows the next year, but actually our brain can't regenerate, so it can't regrow. So it will generate some pathways and they may connect. But if we have a child that isn't then using those pathways, the body will prune them away and they'll be lost forever. So our development of our brain really depends on positive interactions with parents or caregivers and the outside world, but the most important is our parents and caregivers. Okay, so again, this just highlights the importance of those relationships with adults within our lives. and how that impacts on brain development. And actually, one of the most important things is that loving relationship, and that really aids healthy development of the children. So again, another visual representation of that. So this is kind of what we see as the foundation of life and of development. Okay, so we need physical care, we need nutrition, we need love and attachment and a responsive caregiver, and we need shelter and warmth. And if we have all of those, then we can build the rest of our lives on top of those foundations. So if you think of it as a house or a wall, these are the foundations, and then we're building that house or wall on top. Okay, and then we can develop all of these skills because we've got this foundation. If we take away one of the most important elements, so if I take away love and attachment, everything will collapse and everything's chaotic. And this is kind of what happens in our brain. Okay, so there's no stable foundation there. So everything's kind of all over the place, really chaotic, and we don't really know what we're doing with ourselves. So we have to consider as well the role of resilience in our children. So I feel like when I do this talk, I feel like I'm saying it's all really bad and everything's awful. And you know, if you're exposed to these 4 ACEs or more, then you've got no chance. And that's not actually the truth. So it is generally what happens, but we have to also consider resilience and whether a child is allowed to build resilience within their lives as well. So resilience is our ability to recover from setbacks, okay? And it's our capacity to remain flexible and adaptable when faced with challenging life experience. We are all faced with challenging life experiences at some point or another, but how we deal with those and how we bounce back from those depends on the resilience that's within us. So it's why we talk about it's bouncing back, okay? It's how we recover from stress. And how do we develop resilience? Well, it's developed by this really strong relationship and attachment between our caregivers or parents. And it's about being able and allowed to grow and develop in a safe and stable environment. And then it's our methods of developing coping skills and emotional intelligence as well. Okay, so attachment's really important in the first few years of life with parents, caregivers, but actually it's only important for a child to have attachment with one adult in their life, and that adult only has to get it right 50% of the time. So I remember when I was taught this, I remember sitting thinking, oh my goodness, like, have I damaged my children? You know, have I been damaged by certain things, and trying to work things out? But actually, so long as you've got one consistent, stable adult in their lives and they're kind of there readily available for them 50% of the time, hopefully we're onto a winner, and hopefully that child will be able to build some resilience to be able to cope with whatever else is going on in that home environment. These are just different types of resilience. Again, I like visual diagrams because I feel like I remember things better if I see a visual diagram. So thinking about all of our ACEs here, and the types of resilience that could counteract these different ACEs. So we've got children that have been taught how to hope and how to have some positivity, children that have been taught to self-regulate, children that have a trusted adult and a good social network can counteract some of these ACEs that they may experience in life. And then down here, we've got our positive social determinants. So some of it depends on what's going on socially, what our social exposures are as well. Okay, so if we're exposed to negative social determinants such as poverty, poor housing, unemployment, discrimination, that's then going to cause these ACEs to feel worse. And cause us to not develop this resilience. Whereas if we've got our positive social determinants, so we've got access to employment, we've got good working conditions, we've got access to healthcare and community services and cultural traditions and things like that, then hopefully we can start to build resilience against these. So I will try this video, but last time it didn't work. And we'll have a little. Please, can you tell me, Holiday, if you can't hear it?
No,
No, you can't hear it.
no.
Okay, we won't play it then. I need to work that out. Okay, so what is it that interrupts this development of our brain? Okay, so we've said ACEs, being exposed to ACEs interrupts the development of the brain, but why? And it's all around something called toxic stress. So when our bodies are stressed, when we're in a state of stress, we trigger a biological reaction within our body. So we produce a hormone called cortisol, which is our stress hormone. Okay. And basically, when we're suffering toxic stress, so if we're continuously exposed to this stress, these ACEs, it's like revving your car engine for days or weeks at a time. So if you just literally sit outside with your foot on the accelerator for days, the engine eventually is going to break because it's too much for it. And that's exactly what's happening with our brain. So our cortisol levels remain high, which is the revving engine, and then that causes disruption in that brain development. But then, obviously, not all stress is dangerous because we all go through stress, I would argue, on generally a daily basis. So we've got our good stress, which is really good for our body. It increases our heart rate. It increases our stress hormone levels for a few minutes, a few seconds, but then eventually we can bring it back down. So I've just put examples there, like our first day at school, first day in a new job, trip to the doctors, things like that. So think about white coat syndrome, where people go to the doctors and their blood pressure is really high, and then they'll come away and their blood pressure will drop. So that's kind of good stress, and it's good for our body to go through that. Tolerable stress is where we may experience the death of a family member, we might lose our job, we might have an accident. So it's a bit more long term than that good stress, but it's still tolerable because we've got a buffer system. We've got a buffer system within ourselves, but we've also hopefully got supportive relationships around us to help us through that. Because we live in a stable environment with those people that can support us. But then we come to our toxic stress. So example is an exposure to ACEs. And this is where we haven't got those protective relationships because actually the people that we're living with or the people we're socializing with are the people that are providing the exposure to that toxic stress. So they're not going to help us. Okay. So then our body, rather than coming down and bringing these increases in heart rate and stress hormone down, our body's in a prolonged state of stress. So those levels aren't going up and down, they're just staying high continuously. Few more examples of toxic stress on our body. I think we've basically covered all of these, but things like, if we're affecting brain development, we're exposing our children to ACEs, and then they go to school and we expect them to sit still and learn and pay attention to what's being said, but actually their body is in such a high state of stress. They can't do that, and the brain hasn't actually got the capacity to do that because those neurons haven't grown and connected. So then it can impact behaviour. If you think about children in school, if they don't understand, they've not got the ability to listen and take in what's being said, then they start to misbehave because they don't really know what else to do. It can also affect their mood and their feelings and things like that. Our heart, so as we said, that cortisol causes an increase in heart rate. If our heart is continuously at that high level of beating, then we're going to look at, are we going to damage that heart? Are we going to cause strokes? Are we going to cause damage to arteries? Is it going to be working so hard that we've got inflammation in the heart? And then we consider the going back to the poor diet and things like that. So then we're looking at heart disease, strokes, and heart attacks. Our immunity can be affected by toxic stress. So toxic stress impacts on the development of the immune system for a start, but it also makes it harder for our bodies to fight off infection and illness. So we do tend to see children that are going through and being exposed to ACEs have a higher, more frequent level of colds, ear infections, potentially allergies, eczema, asthma, and things like that. And then we look at, you know, the impact of toxic stress on hormones and development as well, and the fact that that can really impact on our growth. It can impact on children going through puberty as well. So what can we do about it? So we need to consider things like trauma-informed practice, education, screening of ACEs, looking at risk factors. If we can get in there early with early intervention and identify risk factors, can we then prevent some of this occurring? So trauma-informed practice, basically is increasing all practitioners' awareness and knowledge of how such trauma like ACEs can impact on individuals. And it's about considering that in an individual's home life, but also in their work life. And there's 6 key principles of trauma-informed practice. So we keep people safe, we keep our colleagues safe, and we allow them to have a safe environment. And we keep our patients and clients safe as well. We develop this trustworthiness within our environment. So again, we're developing trust. So we're allowing people to build those relationships with us and open up to us. We're giving people choice. So, you know, we're allowing people to make those decisions about what they want to do. We're collaborating, so it's not just all about us as one individual professional doing all of this work. We need to collaborate with people around us to enable the best outcomes for our patients and clients. We empower our patients and clients. We give them the information that they need, and we give them that empowerment to make disclosures and to decide on where they want to go next. But we also need to ensure that we consider different cultures within our work and, you know, within our conversations around trauma-informed practice. Education's a really important one for me. So I'm considering looking at, do we bring ACEs into the national curriculum in the UK? Do we educate our children around what ACEs are and the impact of ACEs? So I've just put some information there around the fact that a survey done in 2023 showed that 50% of 18 to 50-year-old parent respondents had no or little knowledge of ACEs. So how can they make a difference? How can they change their lifestyles and the exposure their children are having if they don't understand what ACEs is and how they impact? Okay, so further research really needs to be done into that, and that's kind of where I'm going at the minute with mine. Identification of risk factors and early intervention. So as professionals, if we start to understand what ACEs are and we start to then look at, well, what are the risk factors for this? Is it that parents have been exposed to ACEs in their childhood, so they're massively at risk at then exposing their children? Is there other things that have gone on through their lives that cause them to be at risk of then exposing their children to ACEs? So we need to recognise our high-risk families. We need to identify them. We need to identify risk factors in households. And then we need to observe as well. We need to get in there and look and observe and see what's happening between those parents and children. Is there a good attachment? Are those parents meeting the children's need, or aren't they? And if not, if we're identifying problems and risk factors and observing problems, then we need to start looking at reducing them and changing them by offering early intervention. So we've got different types of prevention. We've got our primary prevention, which is looking at strengthening economic support for families. So can we start to prevent some of the stresses within a family, which then can cause ACEs, by offering economic support? Can we improve mental health services and access to mental health services for parents to then stop that knock-on effect for them then developing and exposing children to ACEs? If we don't get in there in the primary prevention, then we start to look at secondary prevention. So can we screen for ACEs in healthcare settings? Can we offer screening in, say, an antenatal clinic? So while mums are pregnant, can we start to screen then so that we can then offer that early intervention to high-risk families? And if we miss the boat there, then we've got our tertiary prevention. So can we start educating our teachers who are with children every day? Can they start to, can they be trauma informed so that they can start to identify risk factors and signs of ACEs to then make those referrals and start to do some work with those families? And we need to be offering our children that are affected by ACEs counselling and support. Because right now there's lots of interventions in the UK that identify ACEs and offer support, but it's mainly for adults that have been impacted by ACEs as children. So we need to be offering that support to children rather than to adults who were children. So if we reduce ACEs, obviously there's massive benefits because we're going to reduce trauma to children, we're going to improve their brain development, but it's also considering cost as well. So if we consider the cost of all of those impacts from ACEs, so the health issues, the mental health issues, the crime, drug taking, alcohol, incarceration, domestic abuse, all of those things, and the cost that all of those things bring about to taxpayers. So total annual cost, so this has come from 2019, I'm sure it's changed now, but costs attributable to ACEs are estimated to be $581 billion in Europe and $748 billion in North America. And 75% of the costs arose from people with only 2 or more ACEs, which is really interesting because the research previously said 4 or more had the most impact, but actually this is looking at 2 or more. So, you know, even just 2 ACEs is really impacting on cost. And what we've found is that the UK and US economic show that for every £1 spent on prevention, the savings will be between £5 and £10. So that's around 7 to 8 US dollars. So as I said before, we need to be supporting our children. We need to be offering therapeutic interventions as children, not adults. We need to be offering family support programs. So getting into antenatal classes and talking about ACEs and the impact, but also parenting classes. If parents are being referred in for support with the parenting, then we need to be advising them. You know, obviously we're going to be teaching them how to parent, but we need to be talking about ACEs. It's almost a taboo subject and it's not spoken about enough. We need to look at our community and policy interventions. So we need to be looking at our community environments, our school environments, and bringing ACEs into our different policies and advocating for awareness, because as I said, it is a taboo subject. It's not brought into the forefront enough. I think a lot of people are worried about opening a can of worms, but we need to be talking about it because the more it's out there, the more people will understand what they are and what the impact is. And obviously we need to improve around the whole world funding for mental health services, because mental health does have a massive impact on ACEs as well. And then Oladeo, I think it's over to you.
Thank you, Sue, for your presentation. So moving on very quickly to what we know in terms of, largely speaking, the global south. Sue's presentation has really focused on what we know in the global north, and what I think Sue is getting across there is that there are some interventions here. More importantly, the interventions has focused a lot on adults as opposed to children actually going through the having experience of adverse childhood experiences. So in the context of the sub-Saharan Africa, the key point here is that, you know, traumatic childhood events like abuse, household dysfunction does have long-term health impact. In the Nigerian context, if you think of Nigeria, which that is set to become the world's third largest country by 2050, it's really important that we start bringing haste to people's foremind, in order to have an healthy population, and of course a population that will develop and actually give growth to the country. Very quickly, in terms of evidence we have out there, the work by Salau and Owaje from Oyo State, which is a cross-sectional survey, it was really clear that there's a relationship between adult childhood experiences and various socioeconomic, socio-demographic characteristics, which includes neglect and abuse. So clearly, the evidence in the global south is also very relevant in the global north, is the west is also very relevant to the global south. And looking at in terms of the mental health impact as well, we have ACE is linked to increased risk of substance use and mood disorders in adulthood. And perhaps our work environment, you have a colleague that when you talk to them, they perhaps sometimes overreact to what you say. Sometimes a lot of these things are born out of adverse childhood experiences, which I would say, largely speaking, people don't really talk about them to that in that extent. Next slide, please, sir. So thinking of the growing urgency in Nigeria, I've mentioned before the country is on that trajectory. When it comes to risks from ACE, these are key behavioral issues, which is on the rise. People's when it comes to poor academic performances, when it comes to people's impulsivity, ACE can also lead to aggression, and that's based on literature is on the rise in Nigeria as well. We have the adolescent health and substance use. Again, this is a key issue among adolescents in sub-Saharan Africa in terms of the use of substance, and that again has a big impact in terms of people having a healthy life and being able to sort of contribute to the growth of the nation. When we talk about cultural barriers, issues around stigma, so the cultural resistance to discussing childhood trauma, and that itself results to underreporting of these issues, perhaps when they are picked up by healthcare professionals. Next slide, please. Very quickly, in terms of our work at the moment, we are currently doing an exploratory work, exploring the knowledge, attitudes, and practices of healthcare workers regarding adverse childhood experiences and how this is linked to social and mental health functioning. And we really, really particularly focus on the religious and cultural beliefs within our systems. So part of our activities while we are here today, we are trying to mobilize knowledge, what we currently know about adverse childhood experiences. As you can see on the screen, we have principal investigators, Professor Adeshola Gofo, who I think on the call here today, who is our PI from the Ilefe site. We have Dr. Don DeJong, who is the PI for this same piece of work at the University of Jos, also works in Manchester. Myself, Anna, and Zara, public health and mental health nursing, so PIs from the UK, and we've got ethics approval, and we are currently analyzing data from these two different sites at the moment. At this very junction, I will quickly want to sort of bring in Americare Foundation CEO to sort of talk about what they do in terms of the charity organization, and I'm bringing that in because what really led to this was one of the outreaches that Americare Foundation did in 2021 to local schools in Ilefe. One of the findings that came through was more than about 60 or 70% of the young girls that were involved in this survey. I can't recall the numbers now, quite a lot of number, quite a high number reported having been exposed to adverse childhood experiences. And that was what led to this, that if this is happening within those schools, of course, healthcare professionals will also be seeing these things. How are they responding to it? And that was that was the beginning of the conversation that's led to this grant application being funded by LGMU, which is then being hosted by Medicare Foundation. So we invite Mary to talk about Medicare Foundation very quickly. So if you don't mind to go to the second slide, please, so that Mary can talk to the slide. Thank you.
Thank you.
Go ahead, ma.
Thank you, the presenter, Suzanne and Oladayo. Good evening, distinguished guests, esteemed colleagues, and participants. I am Mary from Mary Care Foundation, an NGO that was established in 2019. Our vision is to create maternal and perinatal support to mothers and children. And our mission is to contribute to solutions of perinatal health of women, children, including research. Beneficiaries includes, we have primary beneficiaries and secondary beneficiaries. The primary beneficiaries are mothers and their children. The secondary beneficiary include healthcare workers, researchers, and local communities. Like it's been discussed here tonight, the current projects that America Foundation is serving as a host is the Liverpool John Moore University QR Policy Support Fund Research England 2024. The status of the project is ongoing. Like we've been told, the project is building capacity to prevent and respond to adverse childhood experiences in Nigeria. A study to understand healthcare workers' knowledge, attitude, and practices to inform the co-production of prevention and response activities. And from what has been presented so far this evening, we have been introduced to ACEs and what they are. We have gained a better understanding of how ACEs impacts on lives, short and long term, and we'll be able to consider the benefits of attachment with caregivers and the impacts on resilience, understand what toxic stress means, and what we are left with exploration, to explore what we can all do as professionals and as a community to address the issue. Once again, I want to appreciate the presenters. I appreciate our great distinguished guests, esteemed colleagues, and participants. Thank you so much.
Thank you, Mary, for the quick talk around Mary Care Foundation. And for anyone on the call who wants to sort of work with Mary Care Foundation, I'll drop the email in the chat room that you can reach out to them. So if you don't mind, sort of take the slide back to where we left, please. So I could quickly link that together. Thank you. So very quickly, in terms of where we are up to, so at the moment we are analyzing our data from 2 different sites. But very quickly, I thought it was important to sort of showcase the current, early impact that we are getting in terms of feedback from people who attended our focus groups. As you can see there, and again, this is sort of early impact. What in terms of context, after completing the focus groups, they had conversations, very nuanced conversations, and following that, a week after, they were sent impact form. And people are already, there's slight changes in people's behavior and the way they're thinking about ACE. And as far as we're concerned, the project is, we are making those impact as we speak. I won't read everything. I'll focus just very quickly on the community health officer's comment, who said the group discussion revealed how cultural and religious norms often silence ACE survivors. This awareness has prompted me to focus on creating safe spaces of family to share their experiences. That's one of the feedback that came back from attendees within the focus groups. But we need to do more. You would agree with me, because we need to understand the context these things are happening to be able to put the right interventions in place. Next slide, sir. So very quickly, if you wouldn't mind that's the end of the session we have today. But we have some questions for you to sort of quickly help us as well. So this is the post assessment. If you wouldn't mind to sort of scan the QR code, and answer the questions there in terms of what has changed from your understanding of ACE since you joined this call. But more importantly, it's time for us to, as a collective, to also reflect. And we've got these questions. If you wouldn't mind to sort of type in some things for us in the chat room, because I'm mindful of our time. And the questions are, in the context of Nigeria, because you guys are better positioned to educate us. What do you think are the biggest barriers preventing children and families from accessing support for adverse childhood experiences? How can we tailor interventions to address these challenges effectively? What might these interventions look like? Who might be key partners to engage with going forward? There are very four questions. If you just sort of one, two, three, four, and just write your answers. I would welcome some thought as well at this stage, but I'm just conscious that we need to sort of finish as well. So if you want to sort of give us some sort of feedback or answer these questions by talking to us, please feel free for the next 5 minutes. But if you're also comfortable, kindly leave us some comments in the chat room. Can we take that that's the one hand, and we'll take that comment and then we'll come to summary and conclusion if we are able to. Is the hand gone down? Okay, that's so. So do you want to solve?
Hello.
Go on.
Good evening. I don't know if you can hear me.
Yes, to an extent. Yes, please.
Okay. So my name is Faith, and I'm an educator. I just started out in the academic field in nursing, and my key focus is actually mental health nursing. And I'm so glad this topic has come up, because it is something that I think should be talked about, and has very limited work done on, and Nigerians are not even ready to talk about it, generally speaking. So the first question you talked about, referring to the barriers. The major barriers are cultural barriers, like you identified before. And so societal, social barriers, social norms, and the culture in Nigeria do not prompt people to talk about childhood experiences or childhood trauma, adverse childhood experiences. And Nigerians have a thing for keeping up what they call bold face, so smiling in the midst of pain and pretending like everything is fine. So those are the biggest problems. I can't see the second question. I think that slide has moved.
So do you want to move it back quickly, so please, to the questions? Yeah. Yes.
Okay.
Second question is, how
Okay.
can we tailor interventions?
Tailoring interventions, I think the key targets would be parents, because experiences come from the home. Many of these childhood experiences were experienced by children in their homes. So parents, and then schools, primary schools, even nursery schools, as early as that, children experience they have adverse experiences from teachers, from caregivers, in what we call daycare, what they call crèche in some places. So I think those should be where intervention should be targeted at. Those people in charge of those sort of settings, primary school teachers, nursery school teachers, because some people genuinely do not know what these are. And there's a phrase that says, hurt people who are hurt people hurt people. So those who are hurt sometimes just find themselves hurting other people. So there may even be some of those teachers who have had their own childhood experiences and they've not recovered from it. And subconsciously, they bully children, they do a lot of things to children, they hurt children, and those children suffer from those sorts of experiences. So I think they should target parents, target caregivers in educational institutions, daycare centers, and then finally, even in religious settings too, that should also come in. And of course, we have healthcare workers, pediatricians and nurses and healthcare practitioners across the different bodies who work with children and who work with parents also. So I think that should come in as part of the interventions. And then what might these interventions look like? Generally in Nigeria, if you come with something like this and you just bring it outright to people, they may have some form of resistance because of what I said before. We have the societal and the cultural norms, and those are major barriers. So it can come in as part of the normal assessment process, and it can be done in such a way that it is almost routine like and normalized, and Nigerians in quote do not feel attacked. Because if you come in directly to start asking people, whoa, what kind of experiences did you have and all that, and you just sit them down to have that exact conversation, they may feel threatened and they may step back from answering those questions. But I think there should be some build up to those sort of things in terms of intervention. So like the focus group that was done initially can be also added to that. Now, key partners would be the
I think you've mentioned those words in terms of parents. I'm just very conscious of our time. Your feedback is greatly appreciated, Faith. If you wouldn't mind, I've dropped Medicare Foundation's email at the bottom at the chat room. Please, it would be good to sort of carry on these conversations. And if anyone on the call is willing to sort of collaborate in terms of what the next phase, to join a sort of a steering group to understand how we can move this conversation forward, please put yourself forward by sending an email to Medicare Foundation. The email is just in the chat room. So can we quickly just go to summary and conclusions, please? Conclusions.
Yeah, so basically in conclusion, we have to remember that ACEs have profound impact on physical and mental health. They lie at the root cause of many problems. So it feels quite simple, really, that this is what we need to be addressing and looking at to address many of the problems in society today. We need to be looking at early intervention and trauma-informed care. But for me, we really need to be looking at prevention. We need to prevent this from happening, full stop. While we're thinking about trauma-informed, what we need to be saying is to people, not what's wrong with you, but we need to be asking them what happened to you. So if someone's presenting as unstable, or we've got a colleague that's angry on a particular day, it's not us saying, oh, what's the matter with you? What's wrong with you? We need to be asking, what's happened to you? What is it that's happened to you earlier on that potentially is causing your behaviours today? Prevention of ACEs saves lives, but it also saves money. But it's important to remember that not everyone with ACEs will follow a path that we've talked about today. So not everyone will, have an early death, have ill health, make poor life choices. It's around that resilience building as well, and having trusted adults within their lives that can support that. And basically we need to better inform our parents and caregivers, as Faith's just said, in order to reduce the exposure to ACEs and also the impact of ACEs. And as Oladeo said, with regards to the research in Nigeria and Sub-Saharan Africa, we need to be looking at building this research capacity with regards to ACEs because of the potential growth in population over the next few years and how ACEs is going to impact on that society. Thank you very much for listening.
So thank you very much for your presentation. Damilola, thank you for bearing with us for 2 minutes past the time. I don't know if we just hand over to you, if that's okay, Damilola.
Thank you so much. That's absolutely all right. And we want to say thank you to everyone that has joined this session today. I'm very sure that if we had more time, we would have taken more contributions. And I know that you have a lot to say. You've learned one thing or the other. We've seen beyond, especially for people like us that are living, some of us that are living in Nigeria at the minute, we understand what these things are. For people that have lived in Nigeria, we know one way or the other, we've actually experienced this, and we've seen ways that we can avoid this. We've seen ways that this are actually, it has impacted us, it has affected us growing up, and even people around us. So I want to say that I want to implore us that we should send contributions, our opinion. Let's answer those questions and send it to the email. The email is marycarefoundationofficial@gmail.com, in case you can't see it in the chat. marycarefoundationofficial@gmail.com. And you can message any of the admins here, depending on where you got the link from, to get the email so that you can put in your contribution. Let's work hand in hand with this foundation and these people to put an end, at least to start with the step to put an end to this particular haze. And I want to say thank you to everyone once again. To Mary Care Foundation, I say thank you. To Suzanne Porter, to Dr Bifarin, and to the Institute of Nursing Research, that if they are here, the CEO, we want to say thank you. And my name is Damilola Okola, and I want to say thank you, and I wish you a good night. Bye,
Thank
everyone.
you for having us. Bye-bye. Thank you.